Uh, Good morning, everyone. With respect to the chair and to the audience, today we have a very important topic of discussion like prevention and medical management of diabetic foot. Why this is this much importance? So the diabetes foot complications, if you compare with any other mortalities from this other cancer and other things, it's very huge. You can able to see this 5 years mortalities of diabetic foot is very higher, and those who undergone any diabetes related amputations, the increased risk of mortalities within the 5 years will be higher. So definitely we have to significantly address this issue. This is our idea of discussion here. So this is a prevalence of type 2 diabetes in India. It's more than 101 millions. So if you look this within these populations, then those who have the potential risk of developing diabetes foot related complication, either ulcer or any other things, it's nearly 25%. So nearly in that is amputation risk, it keeps increasing nearly more than 1%. With this thing, why the diabetic foot, it's very important. It's decreasing the quality of the life. We also know that is the fourth or fifth pillar of diabetes management, to improve the quality of the life of the particular patients. So the diabetic foot, obviously psychologically and physiologically, the compromised quality of this particular patients. So again, high direct or indirect cost will be increased. Direct cost will be hospital visits, surgery and antibiotics, so many things will be there. Indirectly, the patients may lose this job, or their who is the caretaker may lose the jobs because of the frequent visit or increased hospitalizations. And a potential amputation risk, either it could be minor or major, and decreasing the life expectancy. So this is the definition of this diabetic foots. It's a foot with the constellations of pathological changes affecting individuals with diabetes, often leading to amputation and or increased mortalities due to the complications. The common initial lesion leading to amputation is a non-healing simple skin ulcer. Actually, it's induced by regional pressure, pathologically linked to sensory neuropathy, ischemia and infections. So what are the pathophysiology of developing diabetic foot? One is vascularity, and the second one is neuropathy. It can be a sensory neuropathy or autonomic or motor neuropathy, then followed by the infection. So what is meant by sensory neuropathy? Just a simple loss of protective sensation of the feet. So it's start distally many times and migrate proximally in the stocking distribution. Many people have the numbness or some not able to feel the sensation in the great toe will be the first most sign of developing the peripheral neuropathy. Some people can extend up to the upper limbs. So this is called stock and glove syndrome, we all know. And again, large fiber loss like light, touch and proprioceptions will be lost, and small fiber loss, it's a pain and temperature sensation will be lost. Many times it's a combination of the both will occur together. Then second one is motor neuropathy, mostly affect the forefoot. There is a intrinsic muscle wasting and developing the claw or toes. It's the earliest sign. So equine contractions. So it's all changes the mechanism of this foot, offloading, all those things. So these deformities will alter the pressure points of this foot and increase the ulceration. Even the patients, just a homemaker also, if they simply stand in the kitchen for more than 30-40 minutes with this kind of deformed foot, may have the chance of developing the pre-ulcers and followed by the diabetic foot ulcers. So third one is autonomic neuropathies. It's regulate the sweating and perfusion of this limb. So loss of autonomic control inhibits the thermoregulatory function and the sweating, and results in the very dry, scaly and stiff skins. Many people may complaining in our day-to-day OP, they lose that hair in the lower limbs and followed by the sweatings loss and dry skins, scales all develop the cracks. These cracks will increase the entry of the bacteria will leads to the infections. This is the charcot. It's most dramatic but less common, nearly 1%. It's a severe non-infective bony collapse and can lead to severe foot deformities and ulceration. It occurs in the long-standing diabetes with neuropathy, but many times the peoples will have the adequate circulation with this charcot foot, as shown in the X-rays. It's just a bag of bones, we can call it, like so complete architecture of this bones will lost. So another one is peripheral artery disease. It's not only common with diabetes, even you can have this peripheral artery disease, the non-diabetes individual with younger populations also. It's more extensive and gender distribution, it's equally have most likely infrapopliteal region, and it's many times poorer outcomes even after revasculation. Unlike our cardiovascular system, it's not very much revascularized in the peripheral artery disease. So here I can able to show this three different type of neuropathy foot ulcers. Like you can see, this is first one is neuropathic diabetic foot ulcer. It's a combination of the all the three, like motor, autonomic and sensory neuropathy. It's ulcers develops in the most prominent pressure areas like forefoot, midfoot and the hindfoots. And the second one is ischemic foot ulcer. It's usually you have the end arteries in the toes, so the gangrene will starts in the toes. Maximum many times it can be a neuropathy also. So the third one is neuroischemic foot ulcer. It's a combination of both the neuropathy and ischemic ulcers. You can able to appreciate this clawing of the toes in the thing and followed by the ischemic ulcers. So what is the idea of prevention this diabetic foot ulcer? Only thing, early assessment and early referral is very important. So what are the cornerstones of this foot ulcer prevention? So one is first identify the at risk foot, that is very important, and regularly inspecting and examining the foot at risk and educate the patient, family members and the healthcare professionals, and ensuring these routine wearing appropriate footwears and treating the risk factors for ulceration. How to identify this foot at risk? Very simple. Ask the history of these patients. Those who come for regular checkup, ask the history about the previous any ulcers or amputation or any claudication, pain or numbness, all those things. So just ask the history and look at the vascular status of this particular patient. Just a simple palpation of this lower limb pulse. Just to keep your footstool in your OP, then just bend down and look at this pulsation. You can prevent some kind of amputation in your patients. So look this loss of protective sensations like pressure perception, vibration and tactile sensation. Pressure perceptions we can able to see with just 10 grams of monofilaments, and vibration perceptions by 128 Hz for tuning fork. If nothing available in your clinic, just touch the tip of your fingers to your toes of this particular patient and ask for this whether you can able to appreciate this tactile sensation. So based on this, the risk stratification as per IWGDF categories, they categorized 4, including 0 category, that is very low risk. That means no loss of any protective sensation or any PADs. This patient is supposed to be screened for every year. Second one is category 1, that is low risk of developing ulcers. Either they have lots of perception sensation or this peripheral artery disease. They supposed to be screened every 6 months to 1 year. And the category 2, it's a moderate risk. Either they have a combination of both PAD and sensory loss, or either one along with any foot deformities, any clawing hand, all the clawing toes, all those things. They supposed to screened for every 3 to 6 months of interval. The high risk populations obviously having the both along with any previous history of foot ulcer, previous low foot amputations, either it's minor, major, and end stage renal failure populations. Also, they are supposed to be screened very frequently, at least every 3 months of the period. How to assess this neurological? These are 5 things you have to assess, either vibration sensation, monofilament test, and pressure, and superficial pain, and reflexes. Just this 10 gram of monofilament assessment is very easy. This is very cost effective. Also, this is not going to cost much. Just place this monofilament under the pressure areas, under the great toe and all the metatarsal areas, and midfoot and the hind foot. You can just push it perpendicularly until this monofilament buckles. So ask the patients whether they can able to sense this feel. And second one is vibration test. It's a 128 tunic fork. Just to put it the same way on the bony prominence under the great toe, and if the patient's not able to appreciate, and you can assess this stockings thing like malleolus or shin of tibia or under the knee also, you can able to see this vibration sensation. Another thing, it's a biothiosymmetry. It's also assess this vibration sensation, because here you can able to quantify how severity of this particular patient is not able to sense this vibration. It's a 20 to 40, maybe the difference will be there. So you can assess the severity of this vibration sensation. Very important thing, how these ulcers, very simple ulcers are developing. Since there is a mechanical defect in the toes, like clawing of these toes or hammer toes, under the area there is a constant repetitive pressure of this area. So obviously the patients develop ulcers and complication that leads to the amputations. So how to prevent this? Identify the most common pressure areas for particular patients. We have these foot pressure studies like static and dynamic. In these studies, they will provide this where the area of high pressures developing on this particular patient's foot. So based on that, the patient's insoles of this foot, if will be modified. Just a simple modification of this footwear just make so much of comfort for this person and improve the quality of this particular patient. And vascular assessment, again, what I say previously, just keep a footstool in your clinic, ask the patient to keep the both foot on the thing, and you can assess this just a palpation of dorsalis pedis and posterior tibial. You have some doubt, is not able to feel this bounding pulse, obviously you can go for ABA or other further vascular assessment that will help. What are the additional points to while examining this high risk foot? One is asking the history. Again, asking history is very, very important in our day-to-day practice. And assess the skin, just color of the skin, temperature, or presence of any callus that is caused pre-ulcerative lesions. So if you remove the callus, if you off-road the particular patients, and you can prevent this further ulceration. And look the bony joints, like check the deformities like claw or hammer toes, and large bony prominence can be assessed, and the joint mobility, the stiffness of this joint can be examined. So this and all will help. You have to examine the patient on the standing and lying posture also. Why the standing is very important? The standing posture, you can able to see this early loss of this arches of this foot. So just correction of the medial arch footwear can able to prevent ulceration in the midfoot, and maybe you can able to appreciate this early charcot can be assessed just by looking the patients by standing feet. And footwear, that is very, very important, and the inadequate and ill-fitted footwear has to be assessed properly. So you have to at least ask the patient to wear the footwear once in a while to in your room to check their footwears. That's very important. And foot hygiene also is very important. That is nails, unwashed feet, and superficial fungal infections, socks, all those things has to be addressed properly. And what the physical limitation of this patient patient, somebody have development of retinopathy or visual impairment or obesity, not able to look their feet down. So you can ask them, keep a mirror, and every day when you are going for sleep, before you keep this going for sleep, you just look the mirror, in the mirror you look the feet, and you can see any abnormalities, just consult your physician or surgeon for the further. And assess the foot care knowledge. This is the most common things. How those who does not have the knowledge, we have to educate them regarding the so many things. Just don't stop simple saying that don't walk barefoot. Immediately everybody will answer, no, I never walk barefoot, I used footwear. But ask the footwear how they are walking. So maybe thin plated footwear does not offload your pressure areas. And many people inside the home, if you ask, I wear socks, sir, I never walk barefoot. But socks does not going to offload your pressure points, just it's a dust protection, something like that only. Sometimes that socks is not washed properly, again that is also make some problems. And don't wear the shoes very tightly, and it's supposed to be have the toe box, and socks washing and other things, it's very important. Don't use any hot water. Sometimes people have the intensity to pour warm water or hot water, because that will reduce the numbness symptoms, that is positive symptoms will be come down. But many times they not able to appreciate the temperature, so that makes some blister formation and further ulceration. And don't use any chemicals or plasters to remove the corns and the callus, and use this lubricants, or so many things are available, oils, but not under the inter toes region, because that moisture will may increase the fungal infection. And cut the nails, that is also is very important. Sometimes we just to patient, just they cut the nails, they got injury, that will develop some ischemia or the foot ulcer. So just educate them how to cut the nails, just straight across, not very go to the close to this toes. Ensuring this routine wearing of appropriate footwear. So just I showed these things. So the footwear supposed to be have the toe box. It's not very narrow pointed shoes, all those things. Even if you likes to wear narrow point shoes, that also supposed to have some toe boxes. Like that you have to customize your footwears, and you can use these appropriate insoles based on the deformity of this foot. So prevention of risk factors for ulceration, obviously the tight control of the blood glucose levels will reduce the development of neuropathy in type 1, because we able to diagnose this type 1 in the very younger age group. But some extent to the type 2 also, it helps to reduce this neuropathy. And the prevention of peripheral artery disease, it's a multifactorial approach. The glycemic control, lipid and BP control is very important. And avoidance of smoking, tobacco and alcohol will further harm your feet. So what is the medical management of diabetes feet? We have, but anyway, we have very limited for this medical management. One is tight glycemic control. That is, various studies shows very intensive blood glucose control either will prevent the development of foot ulcer or at least increase the wound healing time. So that is very important, and reduce the amputation risk. And don't hesitate to use this insulin in those who have the sepsis or foot ulcer. So already on OHS, please change them to insulin if it's required, the blood glucose are higher. Better to avoid SGLT inhibitors, because the chance of dehydration and followed by the euglycemic ketoacidosis possibilities are higher. Maybe it's the small ulcers, non-infective, only trophic ulcer, you may continue the SGLT inhibitor with caution. But if somebody having the extended foot ulcer needing surgical management, better to avoid the SGLT inhibitors. So, and look the general condition of this patient. Many times those who develop the foot ulcer may also have the poor glycemic control, poor self-care of this patient. All those also very common. So look for the anemia and correct the anemia. That will increase the microcirculations of these feet. And adequate protein intake, that is also will helps to improve this wound healing time. And psychological psychological assessment and counseling, that is also very important, because if you say some patients it's bedridden for some 20 days, 30 days, or going to lose their toes or something like that, we have to assess them psychologically and give them counseling, and screening for the other diabetes related complications also very important. So based on this, diabetic foot management is obviously a multidisciplinary approach. This guideline suggests it's a level 1 care. The general practitioner and the podiatrist and the diabetes nurse is very important. And level 2, that we have the diabetologist and surgeon. It can be general surgeon, plastic surgeon, orthopedic surgeon, or those who interested in foot. It will be combined together. And a microbiologist looking at the infection management, and we supposed to have the collaboration with the shoe technicians and the orthotics, all those things. So they may suggest better offloading techniques. And level 3, obviously the tertiary care. It's a combination of all the peoples. So my last 2 slides, like current standard of care of management of diabetic foot in the medically, like you have to assess the vascularity and assess the high risk foot in the early, and infection management with the appropriate antibiotic, and the glycemic control is very important, and surgically we need local debridement and other things, and offloading is also very important. So every 18 seconds there is a lower limb amputation due to the complications of diabetes. WHO and IDF Federation stated that up to 85% of lower extreme amputations are preventable. So please, we act early and prevent the diabetes related amputations. So I'll stop here. Thank you for your patience listening.